Let's see. Camita, Camika, Martha, Christian, Jaile, Monique, Jackson. It's right there. Parker, Lise, Frank, Andrea, so. Okay, so let's do this. So it looks like I'm missing a few, but Williams. Okay, so today we are going to go over commercial insurances. We're going to talk about what the commercial insurance means, or private insurance. These are not insurances that are funded by the government, so they're going to be what we call private insurances. We are going to also talk about how these commercial insurances can have a section that will be managing federal or state funds, and that will be HMOs for Medicare or Medicaid. So we're gonna go over what is the commercial insurance, automobile, disability, and liability insurance. Liability insurance, again, for something that can happen, like in a building, stuff like that. Now we're gonna talk about what they are, what the difference is. We already know a few of them. We're gonna talk about the commercial insurance as a primary coverage, as a secondary, and then we're gonna talk about what the group plans are. So in order to start this, we need to, like always, do a little bit of um, terminology. This is an important part. It says commercial. So not commercial or private or um, insurance that is paid for, and then it's health insurance. We have some other ones, car insurance, disability, and then liability insurance. Again, different from the commercial one. There's some instructions for it, to the commercial claims. We're going to talk about them. And then we're going to talk about what's primary, what's secondary. We already saw that a little bit on the CMS 1500 form. Now we're going to go a little bit more in detail of what it is. And then the commercial part has a section that could be group insurance. And that's where we start building a group of people or a group of clients under the same specific health plan. So in college, for example, have one is a group for the college. A place of employment can have one that is group. Yeah, Medicaid HMOs are put into groups based on where the individual lives, stuff like that. So we're gonna go over them and explain
There's a gating
that
up.
works. Why did
No
it
sé entonces.
disappear? Sorry about that. So one of the things that we need to understand is that we are going to use different parts of the schedules for payments. The number one that we're gonna use is a fee for service schedule. That's how we're gonna get the how you're gonna pay those claims. These claims are gonna be, like we said, we are gonna call them allowed amount. That's how we know it, uh, and it's like what is generally accepted nationwide. Okay, and again, most commercial insurances or private, that's for us. It's gonna be the same, commercial or private. As of right now, it's gonna be the same. Now, it's interesting how it says commercial or private, but at the same time is based on Medicare, so based on CMS. We need to identify what is a primary claim, what is a secondary claim, or what is a primary insurance, or what is a secondary insurance, and HMO, as we know it, how we will impact the way that we decide which one uh, type of payment we're gonna get. Are we gonna get a fee for service? Are we gonna get capitation? So if we have a capitation, it's gonna be some payment that is sent to the provider in advance, usually monthly, for dealing with the patients, and then you send the patients to them. If we have fee for service for non-capitated claims, so those are the ones that we don't send the money, and it's gonna be completely different. So we're gonna talk about how those two work. We already talked a little bit about this last class when we were doing the CMS 1500 form. We were talking about what is a primary and a secondary insurance. So real quick, primary health insurance is the one that is going to get the claim first, okay? And it's going to pay the provider the most, okay? Then after the remittance advice is sent, after we do the calculation and we see what is left over, then that insurance is gonna be that secondary insurance or that other insurance is gonna be send the claim after. So, and you need the remittance advice for it. So simple. Primary insurance is the one that's gonna get the claim first. They're gonna pay. So if we were talking about something like Medicare, Medicaid, and it has an 80-20, so the first one is gonna get that claim first. They're gonna pay 80%, and the rest, the 20%, will be paid by the secondary insurance. So just like we divided it into payment for the insurance or payment for the patient, or by the patient, then here's the same thing: primary insurance and secondary insurance. Like if they were, why this keeps, why? This is not cooperating today. Let's try again. Okay, so what is basically a commercial health insurance is a commercial or a private one. It is not given. It's not a plan given by the government. So it's not Medicare or Medicaid or CHAM-VA or TRICARE. It is something that the individuals are going to buy. So that's why we call it commercial. We also call it individual plan because it's paid by individuals, or sometimes we could do it group plans because it's paid by a group. Number one thing that we need to understand, we have a word called premium. Premium is how much you are going to pay for that insurance. The premium is what you pay monthly. You can pay it every couple of months, or twice a year, or just once a year. Just put it down and you pay. No problem, no problem for the people that are coming back in. Uh, so premium is the the price of the plan. Okay, so if you pay all at once, then you pay the premium all at once. If you pay monthly, then you pay a monthly premium. So we take the premium and we divide it into months. And the depending on the premium, that's gonna give you specific benefits that are gonna be uh, that are according to the premium. So again, the higher the premium, the better the benefits. Basically, that's the case. And then at the end of this class, I'll show you a little example that I like to do that talks about premium benefits, co-payments, deductibles, and how it really doesn't matter what it is. There's a premium, there's some benefits, and the more benefits you want, or the better things you want, the higher premium you have to pay. Group health insurance plan is sometimes it's talked about non-individual or in the group for more. For many places they call it non-individuals. It's going to be a little bit better than if an individual or a private entity will go and pay for it, because usually this is again an entity, an agency, a college, workplace that's gonna buy all of the insurance for their employees or the students or whomever they are at a discount. They're gonna say, "Hey, private insurance, if I buy one, it's gonna be $1,000. What if I buy 100 of them? Would you give them to us for less than $1,000 each?" And that's how we get into groups. And also for HMOs of Medicaid, they're gonna be in groups by geographical area. So when we say private plans, we can use the words individual. So it's basically the same thing. It's an individual or a commercial plan. So in this one is regulated by the states. It has a way of payment that is fee for service. That's how it works. You get a service and and the provider gets a payment. When we put people into different pools, like high risk, or they're gonna have something in the same way, the same symptoms, the same requirements, and then we're gonna put them in that specific plan. But again, not that they're part of a group, not that they're just part of a plan. If any of you guys have had United Healthcare, for example, United Healthcare has commercial insurances, and they name them gold, silver, and they have four. So gold, silver, bronze, and then marketplace. So those are the ones that they have. And if you end up being one of the high risk pools, then you have to pick one of the bottom ones. So it's just putting people into specific areas based on what they need. We also have managed care, and managed care is the HMOs. So if the individual plan, if the private plan has a managed care, we call that an HMO. So I want you to understand that. So managed care means HMO. So and we're going to talk about later about the government sponsor insurance. So if you have Medicare, okay, and Medicare, you have Part C. So Medicare Part C means that you have an HMO, okay? So Medicare Part C HMO is what it means is that a private insurance is managing the benefits for Medicare. So when a patient says, I have Medicare, then if they have an HMO of Medicare or Medicare Part C, they do not have Medicare as an insurance. They have whatever other insurance, whatever private insurance or whatever individual insurance it is. So let's say the HMO is done by Humana, for example. Okay, so Humana HMO is a Part C Medicare. The patient has what insurance? Humana. The patient does not have Medicare. The patient has Humana Medicare as an HMO. So I want you to understand that a lot of people think they have Medicare, and if they have an HMO, they don't. They always give you like the Medicare card. You look in the system, check for their Medicare, and it says Part A, B, and C. As soon as you see C, you go and see which one is the HMO that is managing those benefits, and that's the insurance the patient has. So what I'm trying to say is that if someone has an HMO of Medicare or Medicaid, you are not going to send the claim to Medicare or Medicaid. You're going to send it to the what we call individual health insurance or a private or a commercial insurance plan. That is an insurance plan that is actually managing the account. So that's why it's called managed care. Okay, so they manage the care, or they manage the benefits, or they maintain the health benefits of that patient. So that's something that, again, it's not in the books. It's something that is going to uh, be there for you guys when you are in the work field. It's specifically for HMOs. Whenever the patient shows you, hello, everyone good? No, okay. You look like someone was. Oh.
Professor, can you confirm that again? You say when someone has Humana, does it mean that they have HMO?
No, if they have Humana, so the patient can have. Okay, so the patient has. So let's say that the patient has shows you. You talk to the patient. The patient says, "I have Medicare." Okay, and they give you the white, blue, and red card. Okay, they give you the Medicare card. You still have to look at the system. When you look in the system, it says that patient has Medicare Part A, Part B, and Part C. When you go to Part C, it says that the patient has Humana. Okay, that Humana means that the patient has an HMO or a managed care plan. So that patient does not have Medicare by itself. If you were to submit a claim, you would not submit it to Medicare. You have to submit it to Humana because the patient have Humana. And it's going to be called Humana Medicare. It could be any plan that has HMOs. So it's really interesting that the patient thinks that they have Medicare, but they do have Medicare, but they have it through somebody else. They do not have free, what we call free Medicare. So if a patient tells you they have Medicare, you still have to check if they have Part C. Part C is an HMO or a managed care for Medicare, and that means that that private insurance is the one that the patient has. And you'd be surprised how many patients do not even know what insurance, what private insurance is their HMO, but they will have a card that will say it. So, and it's super simple. You won't get it wrong if you check. As long as you see that the patient has Medicare Part C, then you go like that's managed care, that's an HMO. Whatever it says there, that's the plan that you have to look for.
So Part C is a private.
So Part C, yeah, Part C means that it's a private insurance, private, individual, or commercial. So all of that means the same. That is handling the benefits. So that's a managed care or an HMO.
Got it.
So you see that patient has a private insurance dealing with their Medicare benefits. Okay. Very good. Let me see. What is this? People coming in and out. Oh, I see Monique that I haven't seen. Okay, perfect. Now, group insurance is, again, it's another part of private insurance or commercial insurance that now, instead of being a patient, yes, Monique, I just haven't seen your name. That's okay. You're good. Um, So group insurance is when now we group people into getting the same insurance. So again, usually the easiest way to remember that is an employer-based group health plan or a plan that is paid by an employer. So we're gonna take all of our employees and we're gonna give them insurance at a discounted rate uh, from the insurance company. Like if you go by yourself and buy Humana private insurance, it's gonna be more expensive than if you get it through your employer, for example. So it's interesting how that one works. So it could be that all of the a part of the cost is paid by the employer. So just because you have a group health plan doesn't mean that the insurance is going to be paid by your employer. It could none be paid by the employer, but you will still get a discounted premium if you get it uh, from them by 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 yourself. So covered employees cannot be canceled for anything. And if you quit your job or get a new one, you can keep if you keep paying. And then again, it has some limited plan options, but again, it's usually better than doing it on your own. At least it's the least expensive way to go about it. So quick question here. What is the difference between a group and individual? An individual, you pay by yourself. It's paid by an individual or by an individual, and it's gonna cost X amount of money. But if you go to the group health plan, and that's going through your employer or college or something like that, then it will be a little bit less expensive, and it might or not be paid by your employer. So yeah, remember those. So whenever we say group, commercial, private, individual, all of those mean private insurances. Car insurance. We talked about car insurance last class, maybe a little bit. Car insurance is the insurance policy that you have to protect you from economic loss or if you injure someone. And in our state, it is mandatory, so it's the law for you to have it. So any medical payments or any injuries that you may suffer or somebody else will be paid by the um, insurance, but you need to make sure that you have the premium paid and that you pay your deductible. So the deductible for car insurance is a little bit different than the one for health insurance. So that's how I compare. Let me see if I have a blank. I need a blank space here, maybe around here. Okay. So if you remember, we said that deductible for health insurance, it's a one-time or once a year payment. So let's say your deductible is $1,000 per year in health insurance. So this is health insurance. In car insurance, it could be the same thing. Deductible could be $1,000. What is the main difference? The main difference is that is per accident. So if you get into a car accident and the damages are over $1,000, then you pay that $1,000 deductible, and your insurance company will pay the rest. That's kind of how it works. But if you get into a second car accident in the calendar year, then you have to pay again $1,000 deductible, and then the insurance will pay the rest. In health insurance, a little bit different. Health insurance is once a year. So if you get ill, you go to the hospital, you pay your $1,000 deductible. Then after that, your insurance will pay no matter what, if you get sick again or many times, it doesn't matter. You already pay your deductible. As long as you pay your premium, you have your health insurance up to date, then you will continue. They will continue paying. Car insurance is per accident. You have 2-3 accidents per year, for example. In this year, then you have to pay $1,000 every time that you get into a car accident. It's a little bit different. So again, it's just to offset the payment if you ever uh, get into a car accident. Kind of the same thing in health insurance. Health insurance is for you to use it in the event that you get sick. Now, different from car insurance, health insurance, you use it also as prevention. So you can go um, to your doctor, a couple of times a year to see that you're doing good and that there's nothing that you might need. Car insurance do not have that. So car insurance, they should you should take the precautions on your own. So there's no preventive visits for car insurance, but there are in health insurance. So that's kind of two of the differences. Now, a path where they cross is when um, an individual suffers injury from the car insurance. So the car insurance has to pay for the cars, to fix the cars, and also medical expenses or even funeral expenses for the injured individual. Again, whose car whose car insurance is going to pay? The car insurance of the individual that is deemed um, the the one that caused the accident. Okay, so if someone caused the accident, their insurance is the one that is going to pay. Now, different from health insurance, if you don't have health insurance, basically nothing happens. If you don't have car insurance, then you cannot basically drive a car. So you can buy a car and park it in your house, but you need to have valid car insurance in order to use a car. So again, that's another of the different ones. So they are in many ways are the same. In many other ways, they are completely different. Uh, but sometimes we understand car insurance a lot more because it's something that we need to have and we use, and then health insurance seems foreign to all of us. That's kind of weird. I mean, it should not be like that. Disability again is another type of insurance. Disability insurance means that you are losing income because you are disabled. So sometimes it's called income insurance or disability income insurance. So it's basically a reimbursement or giving money for things after the fact of the income that you're losing because of your illness or injury. So you become disabled for a little bit because of an injury, then you're gonna have that disability insurance. If you have a big disability and something that it's for life, then again you can become disabled, and then the disability insurance will be different. So individuals with disability might have private insurance, Medicare, Medicaid, or any other plan to help for the healthcare. And medical practices are going to have different medical records for individuals that are disabled than individuals that are not, because most of the things are going to be different in the way that we are going to submit the claims. So treatment for disability are going to be kind of reported or done in a way. Usually, what happens is they have a case manager, and then that case management is going to figure out if it's disability or it's any other problems. So you have a disability, they have to go into the disability insurance, usually through a case manager, and everything else goes normal. So that's why sometimes you have to have those things separated. Sometimes, again, they overlap. So when they overlap, then that's where the case manager is going to tell you, okay, this goes to disability, this goes to regular insurance. Again, it's super interesting the way that they do it because usually is after the fact. So when that happens, the service is already given to the patient, so it becomes kind of a problem. So definition or by definition, disability insurance is going to be given to individuals who are unable to do regular activity or work for a specific amount of time. So there's always a ceiling into this disability benefits. If it was the individual was employed when the diagnosis was given, then you need to figure out what the disability is and if it's disability or workers' compensation. So sometimes when an accident happens, we need to figure out if it happened because the patient had something before as a disability or if it happened because of an accident. And again, for the time that the individual is under the care, then they will keep receiving disability benefits. Uh, Now, there's a specific amount of days, and this is important after the disability diagnosis is established, and it has to, like everything else, give a certification. So, medical necessity or medical certification will be needed and required for disability uh, treatment and payments to be given. So, here's where it gets interesting. We need to determine if it's someone getting disability or someone getting uh, unemployment. So it's kind of the two. If it's something that happened at work, or if it's something that happened before and then kind of you brought it to work. So just so you know, some um, some individuals are going to claim disability, and that could go as a crime. If you are receiving workers' compensation, you cannot receive um, the more money than what you're supposed to be getting. So if you combine disability and workers' compensation, you go like, there you go, I get paid twice. No, it's not. Is not correct. If you're in jail or whatever, you are not going to be eligible for disability. And if you do not go to the doctor, then again, you are disqualified or ineligible for disability. So there's a few conditions that you have to meet in order to do this. And the patient needs to know, the provider needs to know, because if not, they're not going to get paid. And again, simple, they get denied and you don't even know why. Um, so disability starts the date of the claim for disability starts with the date of disability, not the day of diagnosis, and then it's calculated. Depending on what it is, it has a base, and that base period is 12 months. So 12 months, and then again it's divided into quarters. So you need to make sure that those things are uh, done properly. So anything that you've gotten before, I mean 6 to 18 months before disability, that's what we're gonna calculate the your actual base for payment. And again, anything that was paid at the time, it will not be included. The payments and the final payments are going to be sent to individual as paid through the estimated date of recovery. And payments are going to be continuing given to the provider until they release the patient from their care. So it's a little bit different than most of the things that we've done before. Before we said you see the patient today and the patient goes home the same day, good, you get a payment for that. Um, and then when you see the patient again, then if you see the patient again, then you get payment. Here's a little bit different. You have to see the patient all the way until they get better, and then is when you basically get you and the patient can get that final payment. Again, 12 months divided into quarters. Liability is the word liability means responsibility. So who's responsible? So that's an insurance for the responsibility of injury or anything that happened to an individual while they are either in a work uh, doing a medical procedure, or they are in, I don't know, in front of your house and there's a hole and they fall inside the hole and they break a leg, then your homeowner's insurance is the one that's going to pay for that. So there's always what we call liability insurance. Liability insurance says that someone is going to be compensated, and it could be pain and suffering. It could be anything. It could be a loss of uh, health or any type of injury, and so who's gonna pay for that is gonna be whomever is responsible. So if you are a homeowners, you have a homeowners liability insurance. If someone falls in your property, then they could get uh, care, medical care, or compensation through your insurance. If you fall at Walmart, for example, then Walmart has a liability insurance for falls and anything that can happen to an individual while they're shopping at their store. So that's kind of what we're saying. It is a little bit different than uh, than the other things. It's gonna be fee for service, but the billing statements are used instead of a CMA 1500 form. So it's a different way of sending the claim. Some claims could get denied, and if they are, then you submit it through a CMA 1500 form to the individual group health plan, and then you give the denial from the liability insurance. So you never, car insurance or liability insurance, you never submit it to the patient's health insurance first, because if the patient fell at Walmart, the patient should not use their own insurance to uh, to pay for the medical expenses. Who's responsible for that? Then Walmart, and Walmart's insurance should be responsible for that. If Walmart says no, uh, for whatever reason, or the insurance says no, then you can submit it to their insurance company, and then you can get paid that way. So the denial again has to be justified. It's not they're gonna say I know all the time and that's it. So a little bit different to what we've been seeing before. Now, here's another word that is important. It's negligence. What does negligence mean? And this is important. Uh, um, Negligence means that you so liability insurance and negligence means that you're liable, that you're responsible for the injuries sustained by the individual because of negligence, because you did something or didn't do something to protect that individual. So when we're doing this, we need to make sure that we can prove it. So if we can prove negligence, then the the if we can prove it, then there's no if we can prove it, there's going to be payment. But if it's not proven, we're not going to pay. So the first thing that we need to do is determine if there was no third-party negligence. So if you can prove that there was no third-party negligence, and then we can prove that there was liability determined or by non-covered negligent party. So that means that there was no negligence, and there's liability of that non-negligent party. Then yes, now we can reimburse. So Walmart has a construction site and it's not covered, and you walk through it and you fall, then they were negligent because they did not close the area off. They didn't have a sign or whatever it is, right? I know whenever there's something spills, then someone has to be there. The cones have to be there. They have to make sure that everybody knows so nobody falls. If none of those things are there, that's when you can say, hey, it was your fault, and that's when you are liable for negligence. But if we can prove that there's no negligence, then yes, we can go to the liability insurance. If not, insurances are not going to pay for those things.
Let's just say it wasn't Walmart fault, it wasn't the store fault, it was just like another driver. So first you go after the other insurance, right?
Say that again. Say that again. Let's say it was
So you see how you use Walmart, like the store, as an example. So if it was like another individual, so you go after the other person insurance, right?
correct. So if you're in somebody, it's like if you're, I don't know, you're walking, and this is something that happens a lot. You're walking, and there's a big hole in the front of someone's, sidewalk, whatever, and you go and you twist your ankle in front of that house. You will go after that homeowner's um, insurance. They will pay. They will have to pay for that. Okay, if they can prove that it was not their fault, then yeah, good. You can go after the insurance. But if it was their fault, then you cannot go after the insurance. You have to go after them. So that's for when it's a little bit different. So the same thing at Walmart. Just because you found Walmart, and if Walmart says, "Hey, it was my fault," then okay. So the insurance is gonna say, "Okay, Walmart, then you pay." So that's what we're saying. You will use your insurance, or the patient's insurance, as a last resource. After everyone said no, then you use, because if not, the patient has to pay out of pocket. The same. If you're in a car accident, the same. You don't go after the car insurance of the individual that caused the accident. If not, you go after them. So, you know. And then if everything goes to south, then you go and you pay using your own insurance. So this is to kind of protect the individual that is from injuries, and having to pay for their medical expenses based on injuries caused by somebody else. No, maybe.
Thank you.
No problem. Okay, so uh, again, we talk about individuals. Now we're gonna talk about commercial. So most of them, again, they could be put in the same category, but this is uh, now it's a commercial because it's now a big group plan. So usually when we say individual, commercial, or private, we're saying the same thing. They're all private insurances. But then the difference between individual and commercial is that the individual is bought by the individual, and the commercial is bought by a group. So usually when we talk about groups, we talk about commercial insurance. So the patient will be covered by one commercial plan, and you will have a group health plan. So it could be a large employer, or it could be uh, or a small employer. It could be an entity, or uh, it could be again, like I was saying, university, colleges, stuff like that. We have the birthday rule. We talk about it. I think we talked about it at the beginning. The birthday rule is when the child has two uh, or more plans given by the parents. So the rule says that whomever birthday comes first in a year. So you take the information from mom, and you take the information from dad, and you say mom was born 6/20. The year doesn't really matter. And dad was born 2/7. The year doesn't matter. In a calendar year, that insurance goes first, or that insurance, that birthday is first. So that will be primary, and mom will be like their insurance will be secondary. So again, this is uh, we calculate that one. So group insurance or commercial insurance could be when we have multiple individuals. So again, an individual that has a company, or an employer could have a plan for their employees, and they just buy 10, 20, whatever they buy. And again, it's gonna be a lot cheaper. Also, by geographical area, we're gonna have commercial insurance or group insurances uh, by the area. Usually, you think Medicare, uh, HMOs are, because it's kind of a national way, but then divided into the sections that they're gonna get, and then because Medicaid is statewide, so I could divide the groups by counties. For example, Miami-Dade County is gonna have a specific number for a group for the Medicaid HMO, for example. Whenever we have more than one plan, then we need to figure that out. What are those? How do they work? So we always will have a primary and a secondary plan. We call it also supplemental plan. So we could have primary, secondary, and then a supplemental plan. It could be a third plan. So the uh, primary again is going to be the one that will pay the most. So the example is always the same. Uh, so we have an 80, 20, and then when we say 80-20, we said the insurance is going to pay 80, the patient was going to pay 20, but also the patient was going to pay deductible and co-payments, right? So I can have a plan that covers that 20%, okay? And I can have another plan, a supplemental plan that covers deductible and co-payment, for example. So, instead of being now the insurance and the patient, it's going to be two insurances. So, like it says here, supplemental insurance is going to be the one that covers deductible, co-payment, co-insurance, some other things. And then the primary insurance is the one that's going to get the bill first. Uh, and this is interesting. When the same payer uses primary and secondary supplemental policies in one CMS 1500 form, then all the payer information should be included in the proper blocks. Remember, the blocks were 11 for the primary and then block 9 for the secondary. Okay? If they are different policies, again, meaning you can have different insurances, then you have to submit first and then submit a second claim with a CMS 1500 form, a new one for the other insurance, but make sure that you include a copy of the remittance advice. So you get the information first, then they say this other insurance is the one that's gonna cover this. You have to, just because they say that doesn't mean that it's already billed. You have to actually bill the insurance. So many times when you send it um, at the same time, then the secondary insurance will deny and say nope. This was supposed to be sent first to the other insurance. So then you submit again, and then when you get the adjudication, then you need to submit again and an appeal. So again, why do we have commercial plans or group plans? Again, if you go to a place that has a plan, a good plan, or a good, or it's paid, then the employers are gonna keep good employees. They're gonna ensure productivity, or again, ensure maximum productivity, and then create a healthy workforce. So that's those three things make sense to for an employer to have their employees have a good health plan that they can afford, and it's going to work for them. So again, it's interesting how many places are including this, and the more they do it, the better it is for the workforce. When we have the CMS 1500 form, the instructions are go to put an X next to where it says group health plan in block 1. So if you remember, all the blocks on the first one said Medicare, Medicaid, TRICARE, and then the fourth one said TRICARE, CHAMBA, the fifth one, um, six, fifth or sixth will have group health plan, and then you mark it. Then you will go to a group number in block 11, and you will put the group number. Again, you're going to have a number for the patient, a number for the plan, and then a number for the group. This is something that you cannot forget when you're doing that. This part is done. We're going to do 2 chapters today, so bear with me. Get the other one. Any questions so far about this? I know it's a lot of information, but it's kind of simple. Health insurance plans can be private or government issued. And here are the examples of of private ones. So we're gonna talk about Blue Cross and Blue Shield. That's the number one, uh, well, the gold standard for private insurances. It was uh, the one of the oldest ones, one of the most influential ones. So we need to use it as an example of what a private insurance uh, is, not should be, but it is. And just so you know, if you want to buy it, if you have some money left over from Christmas and stuff, and you want to buy Blue Cross Blue Shield, uh, it's around like $5 billion. So if anyone wants to buy it, just let me know. We'll put a good word. Okay, so Vanessa, are you willing? No, $5 billion with a B. No,
5 billion. I
B
heard
with
that
a B.
with a.
Jesus Christ! Think about that. Are they making money or not? Of course, they're making money.
I thought you meant like it's worth 5 billion. Like in the market, you can buy something for like you invest $100 and you can make more. I
No, no,
thought
no, no.
that's what you meant.
I'm talking about buy the whole thing. Like you're better. You can buy a basketball NBA team first before you can buy the insurance. Think about that. Like that's so crazy. It is a lot of money. Anyways, so let's go. So no, again, when we talk about Blue Cross and Blue Shield, we're gonna talk about how it went, how did it started, stuff like that. And this almost is gonna be the same blueprint of every other insurance. Molina, Simply, Aetna, uh, Humana, AFME, like all of them are the same. They kind of the same. This one started way back. Uh, so again, some things are a little bit different, but most of the time, every other insurance company, private insurance company, is gonna follow this. So we're gonna talk about Blue Cross and Blue Shield, about the plans, some billing notes, claim instructions, and how to use it as a secondary insurance. So um, Blue Cross and Blue Shield is, I will say, the biggest and the best known medical insurance program in the U.S. It started as two different health plans. So imagine Blue Cross and the what? Blue Cross and Blue Shield, and they were then they were what they say selling contracts into individuals or groups for uh, all a bunch of individuals. So they did it a little bit different. Blue Cross was for hospitals, then Blue Shield was for physician services. But like everything else, at the end they say, you know what, it makes sense to merge, increase the coverage, and increase or like an all-in-one healthcare uh, plan. So that's kind of how this started. And then everybody else, then whenever they created an insurance, they did it that covers both physician services and hospital bills. But again, this is the people that started it. And it has a bunch of other things. So it has what we call uh, the lines of service. So you can have um, Medicare, Medicaid, TRICARE, HMBA, Marketplace, and then specific plans for specific places. For example, Florida Blue is from Blue Cross Blue Shield. It's again, it's a different section of Blue Cross and Blue Shield. So an individual can have Blue Cross and Blue Shield here in Florida, but they could also have, or other individual can have Florida Blue, and there are two different plans. So again, you have to be careful with those things. Uh, it started 1929. It was the first groups that were doing it as a prepaid. Um, we're teachers, and it guaranteed 21 days of hospitalization per year, and the premium, and again I say premium is the price of the plan per year was $6. So yeah, so if you're paying now like probably like 300 $400 a month times 12, that's gonna be your premium. So premiums now are $3,000 $4,000, even more. Probably like 600. Like let's say now it's $6,000 a year. So in 100 years, they're charging 1,000 times more than what they did in 1929. So think about that. So again, it was a way of getting into the business of using better ways to do business in healthcare. So it was approved basically by the American Medical Association. They said, you know what, if you want to do it, just try to get in, and they started doing that, and it worked. So the first kind of plan was for we call it California Physician Service. So 1939. So by like the first 10 years of it, then they were there, but not it was not a thing that everyone was using. So it was more than an idea; it was a concept that was put into play. And one of the things that helped was that the doctors were saying, "Sure, why not?" You know, instead of charging this patients, I can charge an insurance company, and it will be you know, hopefully better. So again, it started going kind of tiny, independent, community-based, and locally operated companies, and then it grew into the giant that it is now. They did the trademarks for it. They made companies of it, and then they went national. So when we talk about Medicare and Medicaid, when we talk about CMS, we talk about TRICARE, we talk about all the governmental plans. We always, or I always say Medicare. So I can say, when I say Medicare, I mean all governmental plans. When I say Blue Cross Blue Shield, we say uh, all private plans. So the gold standard for insurance plans, private ones, it's going to be Blue Cross Blue Shield. Any new plan that came up will be following the steps of Blue Cross and Blue Shield. Any other governmental agency will follow Medicare, but at the same time, Blue Cross will follow Medicare too. So kind of a way of merging everything. So at the beginning, it was kind of a non for profit because they wanted just to have the thing running. So it was like, okay, I'll give you this money, and then I'm just offsetting the money. It's just exactly what we're doing now. If you think about it, your insurance plan is just like a bank account where you're just putting money just in case you get sick. Basically, that's what it is. So at the beginning, that was what it is, and then they say, well, but if enough people, if I get people not going to the hospital or not getting sick, then I can make a profit of it. So they change it into a for profit, and yep, and they're doing really good. So how do they kind of got people? Well, the way they did it is the way every single plan does it. Is let's now put people in business. So I'm gonna draw this again. I did it in the beginning of the class, and I'm gonna do it again. Insurance provider. Okay, so patient, provider, insurance. That triad of individuals, that party of three that we have there, uh, needs to be in kind of in cahoots with each other. So what they started doing is say, hey, you, and then they were talking to the patient. Okay, I will provide those services. Okay, I will provide. You give me the money, and I'll handle all the claims and all the things from your providers. And then they said, hey, providers, I got a bunch of patients that are doing this, uh, and if you get networked or in contact with me, then it's gonna be a good thing. And then those patients are going to see those providers, and the whole thing becomes this working fine oil machine. Uh, so the members are gonna receive the 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 services from the providers, and the providers are going to receive payment from the insurance as long as the patient pays their insurance. So it became a thing that everyone that was on this network, and we also call it an umbrella. So now for that, I'm going to draw a big umbrella here. So if you are under that umbrella, I will do that backwards. There you go, my umbrella. So if you are under that umbrella, all the providers that are under the umbrella, all of the patients that are under their umbrella, and again, all of the insurance areas that are all together. So what they will say is like everyone there will pay less. Everyone will benefit from it. The provider will benefit, the insurance will benefit, and the patient will benefit. Now, the patient might want a provider that is out of the umbrella, out of the network. So that provider that is all the way here, okay, will not get the benefits of being under the umbrella. So if the patient wants to pay that provider, they'll have to pay more. Okay, so if you want to see that provider outside the umbrella, outside the network, outside the participating provider, then you have to pay more. You're gonna pay. They're gonna pay. Uh, Actually, you're gonna pay less. The insurance is gonna pay the provider less, and whatever the difference it is, you're gonna pay it out of pocket. So it was still giving a chance of seeing a provider that was not on network. So network means that they are under the network or under the umbrella, and usually what happens is that people go with the providers that are under the umbrella because it gets a little bit better. Is cheaper to do. Yeah, and the quality of service should be the same. So utilization management programs evaluate healthcare accessibility, appropriateness, cost effectiveness, medical necessity, quality, treatment plans, all of it, and they're gonna say, okay, this is a plan that we need for these people in this area, and then they're gonna create a plan based on that. Every single plan does it like that. Every single plan will do it like that. You want a new plan? You wanna open a plan out of your garage, you still have to check what goes where and how many patients, like all the things that you might need. To keep it super simple, they started it because they started with the doctors. The doctors were the ones that they gave the okay first. They say okay, fee for service, simple. I do a surgery, you pay me. I do a visit, you pay me. Uh, and that's the main business that they have. Okay, so it's always fee for service. Now, as we started changing things a little bit, then we have the indemnity plans, we have the managed care plans. Again, like the examples for disability or workers' compensation. Workers' compensation for the federal employees is the federal employee program, and then they go like, you know what, like a lot of people are getting Medicare. Again, this started after the plan started, and they say, okay, so we could be a supplemental plan for Medicare, and that became a big thing for 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 Blue Cross and every other plan. And again, they have some healthcare anywhere. Again, now international plans, things like Blue Cross 365. Again, discounted health, wellness products and services all the time. So now, if you think Blue Cross, well, Blue Cross will have things like this, or I say Blue Cross Blue Shield, but it could be any other plan. So each plan will have different what we call lines of business. So you're gonna have private, okay, individual, and you're gonna have commercial. You're gonna have Medicare. You can have Medicaid. Okay, you can have workers' comp. So you can have all of them. Okay, and then all of them are gonna be specific to an area. You could have international plans. So whatever Blue Cross puts out there, everybody else is going to follow. So the fee for service is again, it's a traditional one. It's the one that we know and understand. That's the one that we get for individuals and for the commercial ones. So we have what we call basic coverage. So that is you go and you get visits and you get normal things, basic things. Then major medical, it talks about hospitalization, and then long-term conditions, cancer, surgery, stuff like that. So you can have major medical, major surgical, basic coverage. So you can have dental. So we can add things to this. So I can say here, okay, now I want dental. Now I want surgical. Well, the more things you put, what's going to happen with the price? Well, the price is going to increase. Okay, increase. So the premium will increase. So whenever people say I have a plan from my work, then yes, it will have, and this is the thing that it might have. You might have it's true, okay, as normal coverage. And again, we keep saying that it's if you go outside and buy it without your employer, it's gonna cost you, let's say, $1,000 per year. So what the employer is going to do is going to tell Blue Cross Blue Shield, hey, I'll buy more. I have 100 employees, 1,000 employees. So I'll buy insurance from you for them if you give me something else. And they will say, okay, I can give you that same thing. Okay, basic coverage and major medical for $800 per client. Okay, or I can do it at $1,000 and I will add dental, for example. Okay, and that's how those things go behind the scenes. So depending what they are, what they do, then that's gonna be the prices. But the fee for service is the one that you're gonna use the most, because again, that's the one that has to do with uh, uh, seeing the patient and paying exactly for what it is. Now, then we said, wait, Medicare, Medicaid, and Medicare are booming now. So let's figure out how we do our managed care plan. So managed care, again, is a healthcare delivery system. It controls the patient's or the services that it's going to be received by physicians, by hospitals, or other healthcare providers, and they're gonna just tell the group, this is the money that I'm gonna send you. Based on what I'm getting, this is what I'm gonna send you guys. Now you have to see the patients. Okay, so they're not receiving payments per service. It's not fee for service. It's what we call a capitation. So it's called capitated payments. So I'm gonna send Dr. X. I'm gonna send him a check for $10,000 a month. Okay, and he's going to see all the patients that I send from the insurance, and he's not going to. He's gonna do the forms and everything, but he's not gonna get paid for every single thing that he does. He's gonna get paid for just being there for that month. Okay, so it's called capitated or capitation. So in that one, usually you'll see a lot of claims that when you send them, they will they will say something like denied or paid in full because of capitation. So that means that you're not gonna, or payment zero, paid in full. And you're like, wait, what? So it's because of capitation is in place. So capitation means that the plan is gonna send that money to the hospitals, to the doctors, to whomever it is, for treating those patients. And the plan is going to make sure that they send those patients to the doctor. So the doctor has to do less work of the administrative, more of seeing patients. And it becomes a really good way of, making practices work really good. So then basically the doctor is creating its group of patients based on how good or how bad he is, and insurance is making sure that their patients or clients are being seen by doctors. So every part of the administration, the coordination of all those things happen at the hands of the plan. So that's why the plan is managing all the things. And again, the doctors, hospitals, and facilities can just focus on the care for the patient. Now, they could have different names. I keep using HMOs. Whenever I say managed care, I say HMOs, but there are a few ones. So they're all called managed care, but in the industry, we call them all like HMOs. But they could be HMOs or they could be EPOs. It could be a few others. So EPO is called Exclusive Provider Organization. That is when the patient can only see in-network physician hospitals or the healthcare. So exclusive provider organization. So you are going to only see patients that are in-network. Okay, so patient must obtain services from on-network providers only. The patient is responsible for charges. Okay, so if you see someone outside the umbrella, like I said before, well, this time, okay, if the doctor is outside the umbrella, provider is all the way here, there's no payments coming from the provider, from the insurance to the provider. It has to come from the patient. Now, health maintenance organization is a little bit different. It's now the 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 plan basically is taking some of the risk with the provider, so they do it a little bit different. So they're saying, you're gonna see my patients, but you're gonna see my patients at 50% of Medicare allowable. So when we say Medicare allowable, we said let's say $100. Okay, Medicare will pay 80-20, right? So that means that the patient pays 20% and the Medicare will pay 80. So, and in HMO, the insurance is saying, hey, I will pay 50% of the Medicare allowable. So now the doctor is going to get $50 from the insurance company. If they do Medicare, they will get $80 from Medicare, and then $20 from the patient. So here, they're going to get $50 and maybe they'll get $20 from the patient. So it's always at a discounted rate. By doing that, the insurance company gets to keep a little bit of the money, and the doctor the doctor loses a little bit of the money, but the patients are going to be sent by the insurance company. So it is kind of a win-win for both. But again, that is both of them assuming risk in seeing the patients. And then the patient will have to pay more premium to get a better plan. So it becomes like everyone now has to share the loss. So outpatient pre-treatment authorization plan. So now it's the plans will have pre-authorization for almost every single thing that they do in outpatient, physical, occupational, and speech. Any of those things, anything, will require pre-authorization. So it is the sole prospective plan that we have. We're gonna figure it out first, and then we're gonna pay. Retrospective was better going back, and it had pre-certification. So before we do something, we're gonna ask the provider, hey, figure it out. This is what we're gonna do. Let me know if I'm gonna pay or not. So there's a bunch of things that we need to do in order to get paid. It's kind of interesting how that one works. And again, it's only for some specific healthcare system. So again, if you ever see that, just know that you will have a lot of pre-authorization, pre-certification to do. You will have to do that anyways with HMOs, with managed care. Medicare patients will require referrals, pre-authorization, pre-certifications before any type of procedure that is not a visit, including a visit if it's a specialist visit. So managed care point of service is a little bit different. The subscriber will choose a network or another network. So you're giving them the option to say, hey, what are you going to do? In-network or out-of-network? Now, quick question. What do you think is going to be cheaper? Getting someone in-network or getting someone out-of-network? Well, super simple. In-network will be cheaper. So if I pick in-network, then payments are going to be less, or at least out-of-pocket payments. If I pick out-of-network services, then it will require out-of-pocket expenses. So co-payments usually start getting higher. So managed care point of service will have both inpatient and outpatient services. And you're going to pick a primary care physician or a PCP from a list. And what are you going to pick is a PCP that is in network, okay? And that individual is going to be the gatekeeper um, or the responsible for moving the patient through the system. So if you want to go to a cardiologist, or you need to, then you go to your PCP first. The PCP says yes, a referral for the cardiologist is needed. Then you go to the cardiologist. Um, why we do that? Because if you go to the cardiologist just because and you don't have to go, you didn't have to go, you wasted the time of the cardiologist, you wasted the money of the plan, and your plan and your money too. So the best way is, let me take you to the primary care physician, and if you don't have to go to a cardiologist, and the primary care physician can figure out what you have, then we just everyone uh, got better. So we did not waste the money, you did not waste the time, and the cardiologist is free to do to check other patients. So again, it's interesting. So we call it gatekeeper. So whenever you see gatekeeper, gatekeeper is the same as PCP, primary care physician, the individual that is there uh, uh, to keep the gates of the money closed, so we don't waste money and time of everyone involved in this. But again, if they say that you should have gone to the cardiologist, they'll do a referral and send you to a to to the specialist, and then the insurance company has to pay for that because it has a referral from the PCP. We're just following their orders or their guidelines. Managed care plan, preferred provider organization. So now it's a preferred provider. So that's PPO. So we have an EPO, HMO, and now we have a PPO. So PPO is a preferred provider organization. So before we didn't have coverage for out of network in the EPO. In the HMO, they have out of network coverage, but you have to pay out of pocket, and it's gonna be less or actually more for the patient. Here it covers uh, providers that are out of network also, but this is gonna be more money, so the patient will have to pay higher premiums. Not that they will have more co-payment or co-insurance, they just have a higher premium. So this is a slightly better or more flexible insurance, so you have to pay a little bit more for it. So again, this is the people are extremely in love with PPO because, oh my God, I can go to any doctor that I want. But you know, it's exactly the same care, exactly the same thing. Just it's a little bit more expensive because it just covers more things. One of the things that it will, as an example, one of the things that it requires is mandatory second surgical opinion if you're doing non-emergency or elective surgery. So if you're going to do surgery and the plan is going to pay for it, they require a secondary opinion to see if there's a better procedure, a better thing, or something that basically is cheaper for them, so they can keep a little bit of the money. So EPO, the cheapest, HMO a little bit more expensive, PPO a lot more expensive. For all of this is for the patient, or the provider is exactly the same. If you are a participating provider, you're gonna get paid anyway, regardless of what the plan of the patient is. Now, federal employee programs. Again, this is for benefit program for federal employees. I was implemented in the 60s, actually 1960. And again, everyone that was working federal employee, dependents or survivals of the employee, will have this plan. This plan, sneaky, was underwritten and administered by Blue Cross Blue Shield uh, insurance. It's a little bit different, but the service location is gonna be the local Blue Cross Blue Shield area, so it's a little bit different than everything else. Uh, and uh, and the patient will receive health care services regardless of members' plan affiliation. So again, this ensures that doesn't matter what plan you have. Like in this example, you're gonna get the care. So that kind of trickle down to the rest of the plans. And in this beautiful country of ours, if you get sick, they will save your life. If you get an injury, if you get an injury into an accident or whatever, they will save your life. They will do everything in their power to do it, and then they will figure out how to charge you. So this came from, again, the Fair Employee Program, and again, sneaky, it was done and administered by Blue Cross Blue Shield. Example of a card. Again, it doesn't really matter what card it is, but we're talking about Blue Cross Blue Shield. This could be any plan, anything. Okay, so the card will say a few things. Like this one says PPO, so you know that that's a preferred provider organization. This is the insurance company, ABC Insurance Company. It is a national account, whatever. And then this is the patient's information. Usually this customer and provider service is in the back of the card. So whenever you have a card, you flip it to the back, and it will have two phone numbers. One for the patient to call customer service, and one if you are a provider. And this will be the ID for that patient. This will be the group number. Okay, usually group number will be something like this. If you have numbers after that, they could be the dependents. So for example, Jack here is 00, so he's by himself. If instead of having 000, we'll have 001, then that means that there's a 002, 003, and that could be any of their family members that are included. Something that is extremely important for most of the plans is the effective date. So when it was done. And then in this case, it says family plan, and then again, it has some other information. It could have co-insurance information. It could have co-payment information. I could say here, for example, PCP, no charge, or $5 copay, ER, $200 copay, whatever. Like it might have more information there. And usually, when you have something like this, you will have a website for the insurance company where you can actually check that individual by name, and then by doing that you can find what information of the actual plan you have. So next class we're going to talk about Medicare, then Medicaid, but because Medicare it pays at an 80-20, so the individual might want a supplemental or a secondary insurance to deal with the 20% plus the deductible and co-payments. So Medicare supplemental plans are going to do that. It's an augmented Medicare program that will pay for deductibles, co-payments, and co-insurance. And anything else that is not paid by Medicare, but you want to do it. So again, because Medicare is given to specific individuals that are 65 years or older with Social Security benefits, disabled before 18, and stationary disease patients. So they will still have to pay that 20%. So let's say it's a retired individual, 65, he has it, he does not want to pay that 20%, and he has the money to, so he could get a Medicare supplemental plan. So basically, we are covering the gaps of Medicare. So we call them Medigap plans. And they usually the card will say Medigap. So if you go back to the card that we just show, so here where it says here where it says FAM, here it will say, for example, Medigap. Okay, so it will cover whatever is left over after Medicare has paid. Okay, so deductibles, copayment, co-insurance. If you see this, this is exactly what a patient will pay when we do an 80/20. So if you do an 80/20, okay, and I know some of you are really good at the math. If you remember, the payments for the patient will be the allowed amount, okay, minus deductible times co-insurance, and the whole thing plus deductible and co-payment. Okay, so deductible there, co-payment there, and co-insurance is this, the percentage of the allowed amount minus the deductible. So if you don't, as a patient, you don't want to pay that, then you can get an insurance that will cover those costs. It will cover the gaps of Medicare, so we call them Medigap. Okay. So healthcare anywhere is a concept that allows members to access healthcare benefits throughout the United States and around the world. So it's an international one. It's kind of interesting how that one works. It's just the card says that it's gonna be paid, so it's called out of area coverage. So again, you'll have your Blue Cross Blue Shield plan. It will work, in the state that it's. No, I'm lying. So let me rewind a little bit. If you have Florida Blue, you have Blue Cross Blue Shield at from the Florida, and it will work in Florida. I want to say Publix employees and some other employees that their headquarters are somewhere else, they have Blue Cross and Blue Shield from Georgia, for example. They do not have Florida Blue, but they are in the commercial group plan of Publix, for example, and let's say it's in Georgia. So what we're saying is that if you work for Publix, you will have Georgia Blue Cross Blue Shield. So it works in Georgia and it works here because of that arrangement. Okay, and then your PCP is gonna be from here and your whatever. But if you want to go anywhere in the U.S. and anywhere in the world, then Blue Cross and Blue Shield was one of the first ones that actually created this and worked. So you have Blue Card, Geo Blue, and Blue Cross and Blue Shield Global. So all those are plans that are going to pay the providers based on the benefit plans for that individual. So again, you go to different places in the world, then that's something that you might see. It's not super common, but I would say you will see one or two of them a year. So you'll see that they have international plans, and usually it's of the Blue Cross variety. Okay, so that's yep, people, that's about it for that. Real quick, let me show you something here. So there you go. Geo Blue, it's for short term, so people that are going to travel short term, students or people that are staff for a company or whatever it is. That works really good. And then a blue card is for people that are not living in the US, so they actually move. So they're paying for the plan here. And Blue Cross Blue Shield Global, it's a company based in Europe. So it's now, again, a little bit more close to what we're doing. So they started here and they move over there. Okay, a few more things. Blue Cross Blue Shield billing notes and claims coverage. Claim processing are gonna be submitted to the local. So this is what I was saying. So local Blue Cross Blue Shield payer. So if you, the example of public employees that have Blue Cross from Georgia, we're not gonna send it to the plan. We're gonna send it to the local payer. Deadline for filing claims is 1 year. This is following suit for Medicare Medicaid. So again, most of the claims, just like Medicare and Medicaid, have 1 year. Not many of the private plans have that. Claim that they use is a CMS 1500 form for professional services on the UBO4 form for institutional, or the 837P and 837I. Uh, Again, some will have inpatient and outpatient coverage only, and some others will have surgical. So the one that don't have surgical will usually require a secondary or second surgical opinion for elective procedures. So again, a few different things from a bunch of the other ones. Deductibles and co-payments usually follow suit with Medicare. So co-insurance 20 and small deductibles per year. Allowable fee determination, it depends on the plan. So some plans are going to use the physician fee schedule. That's the one that we showed you for Medicare. So this is, they're going to use the allowable Medicare amount. Others will use what we call the usual, customary, and reasonable basis payment. So what is used in that area, that's what we're going to use. Assignment of benefits is made directly to the provider. So that's just like Medicare. And a specific thing that again is used in many of the insurance companies is that when you see the patient, you need to get a copy of the front and the back of the insurance um, ID card. So this is something that all the places will do. So they will just take a copy of both the front and the back of the card, and resubmit claims if they're not paid within 30 days. So in Medicare, you're supposed to get what we call an adjudication. That is a determination of payment, non-payment, rejection, or denial of a claim uh, within 14 days. So within 14 days, if you don't get payment, then just wait one more day and you'll have it. Or denial or rejection for Blue Cross Blue Shield is 30. So they give a little bit more time, and then you can do the resubmission. So basically, they're saying 30 days instead of the 14 for Medicare. And again, this is something that you learn more in the practice, but it becomes easier to do when you do it every day. So Blue Cross Blue Shield has primary claim status when the only policy is Blue Cross Blue Shield. If it's an employer or a group health plan, and if it's a governmental plan like Medicare or Medicaid. If it's a commercial or individual plan, and if it's listed as a dependent, so the patient could be a dependent in other plans, so we still do it as primary. So again, Blue Cross Blue Shield, like really good for or easy to work with. If it's secondary coverage for maybe for Blue Cross Blue Shield, then there's some primary plan. And again, that primary plan could be because of a patient has two plans. It's a kid that has mom and dad. It could be that the secondary plan gives kind of the same coverage. It could be a supplemental plan. So if it's a supplemental plan, then it's gonna be secondary. And regardless if it is primary or secondary, we're gonna use only one CMS 1500 form because both Blue Cross Blue Shield are gonna be both payers. If it's a different one, then we have to go to the things that we said before. We need to do one first, and then remitting advice from the primary payer to send it together. Okay, so let me go back just to one that has a bunch of space so I can write something. For example, this one. Yeah, so here. Or let me do this. Let me not do this. Any questions? Any questions so far? Anything? Awfully quiet, my people. No.
Few quiet information.
It is, but it's at the same time is for every single private plan it's gonna be like that. So that's why we include only that one. I do not have space to do that. Let me see if I can do it here. So I want to show you guys this is kind of weird. It's not letting me even do any edits on this. But okay, I'm gonna again ignore all the top. No, don't ignore it. I can do this. Why it's not disappearing? Oh, there you go. Okay. So this is how insurances work, and this is something that you might not be aware of. Maybe you are. Anyone sells insurances for a living here? No one sells insurances. Okay, so this is a way of me explaining how things work. So we're gonna make our insurance plans. We're gonna sell insurance plans. Okay. So the first one that we have is Medicare. We have why are you not right? Oh, we have Medicare. Okay, Medicare. I'm gonna do a little table here. Okay, so Medicare has or different insurances. Now do different insurances. Medicaid, we're gonna do TRICARE, then we're gonna do a private, and Medicare, Medicaid. We're gonna use TRICARE. We're gonna do Chunk VA. We're gonna do private. And we're gonna do Obama. Okay. So then we're gonna ask questions. The questions are gonna be how much are we going to pay for things? Yes. No. We're gonna say down payments. Down payment. We're gonna say monthly payments. We're gonna say deductible. We're gonna say co-insurance. We're gonna say copay, and then we're gonna say premium or okay. So so Medicare has no down payments. Okay, Medicare has no monthly payments. Medicare has a deductible. It's a little bit less than $200. Medicare has a co-insurance of 80/20. Medicare has zero co-payments for the most part. And at the end of the day, Medicare is around $1,200 per year per individual. Okay, cool. Medicaid is kind of the same thing. Medicaid has no down payment, no monthly payments. It has no deductible. It does not have a co-insurance, so it's 100%. And it does not have a co-payment. And at the end of the year, it costs $1,200 for the state. FICAR is the one that is for active military. So if you're active military, you have no down payment, no monthly payment, no deductible, 100%, and no co-payment, and it charges that to the federal government. MBA has no down payment. It has monthly fees around $100 per month. Usually no deductible. There is a co-insurance of 80/20, and it has co-payments. So again, I want to put co-payments like really low co-payment, but $5 per visit, for example. And at the end of the thing, the premium cost $1,200 to the MBA. Now, here's the private. So who's willing to talk today? Who's willing to put their voice out there? Actually, we should do two of these ones. Let me just real quick. I need someone that's willing to talk. Go. Bye. Yo. Anyone? I'm gonna call you by name then. Anyone? I need a volunteer. Dale. No problem. Let's not torture you. Go. It's Lane. Come here. Tell me. Do you have money?
Here.
Do you have money? Yes or no? Do we have money? Do we have money? Are you loaded? Do you have money? Yes or no? Yes.
I guess, yeah.
Yeah, you have money. Okay. So because you have money, you are going to give me a down payment for your private insurance. Okay.
Okay.
600. Is that cool? $600. You have it now. Let's do it. $600. Okay.
Mm-hmm.
Let's jump the monthly payments now. Do you want a deductible? Yes or no?
Yes.
Yeah, but it gotta be at least $250.
Okay, there you go. I'm good with that. $250 deductible. Because it's a private insurance, we're gonna go with 80/20. Quick question: do you want co-payment? Yes or no?
Yeah, I don't mind the copay.
Okay, so let's do $10 co-payment because it's private. And now we could take the deductible plus the private insurance or the down payment that you put. It's $850. So whatever is left over of the for the $1,200 is what we're gonna do monthly payments. So you're gonna say, okay, so I had let's do it like this: $600 plus the deductible, or basically the out of pocket, is $850. That minus 12 is $350 divided by 12 is $30. So you're gonna pay $30 per month. That sounds right? Sounds good?
Yeah.
Okay. And you look at the end of the year, your plan cost the same, $1,200.
Yeah.
Now, if it's Lane, bro, this is bad. We don't have money. Now you don't have money. Okay. Now what? Do you have money for down payment?
No.
Well, no, you don't have it now.
Yeah.
Do you want a deductible?
No.
No? Okay, whatever you want. Here you go. No deductible. Okay. Co-insurance, we're gonna do 75-25 to help you out. Okay. And co-payment, we're gonna make it a little bit higher. Okay. So now you owe me the whole thing. If you see, you haven't given me anything down payment, no deductible, so the whole thing has to be divided in 2 months. So the $1,200 has to be divided into months. So 1,200 divided by 12, it's $100. So now you're gonna pay $100, and at the end of the year, your insurance cost $100.
But what if I get a little credit to assist me with the costs?
Well, you know what that is? You know what that is? A little help. It's called Obamacare. It's Obamacare. Okay. So now you're gonna tell me no to every question that I ask you. Okay.
Okay.
Do you have down payment?
No.
No. Okay. Do you have deductible? Do you want deductible?
No.
Okay. Now again, it might help you out, but not giving you the whole thing. So let's do a 50-50. Do you want co-payment? No. Okay?
No.
So look, at the end, we have to do it the same thing. This is the price that you have to pay. So again, Obamacare, for example, will be no, I'm lying. I asked a wrong question. You don't have money, right?
Right.
So you cannot pay me monthly anything, right?
Right.
Oh, okay, so don't pay me monthly. That's okay. Look, I work too. Obamacare says that you can. Okay. So now no monthly payment, but you owe me still $200, so that will go to deductible. When you pay your deductible, then you have insurance.
Oh wow.
If all of you look at all of those descriptions, what all of them have in common is this: that at the end, I don't care what plan you have, the premium is more or less the same. In this example, it was exactly the same. Okay, so either you have a small deductible and the rest is paid by the government, or no deductible and no monthly payments and it's paid by the government, or the whole thing is paid by the government. I mean, if you're in the federal government, or a part is paid by you and the other part is paid by the VA, or you do monthly payments and you pay the whole thing, or you give me a down payment and then you give me some deductible and then you give me a small monthly payment, or you pay the whole thing in monthly payments, so you don't have a down payment, so you don't have a deductible, so at the end it's the same. Or you just say, I don't want to pay down payment, I do not want to pay monthly, I do not want co-pay. Okay, so the whole thing, okay, the whole $1,200 is gonna be deductible. So it does not matter what insurance the patient has. That's how it's going to be. Okay? If you want to understand it in a different way, think about these are ways to buy a car. Okay? All of those are ways to buy a car. The first one, okay? This car is being paid by who? By the federal government, Medicare. Okay? And you only have to put down $200 a year, and the rest will be paid by the government. Medicaid is paid completely by the state government. Biker is your car that is paid completely by the military. VA, the VA is going to help you out a little bit, but you still have to pay almost the whole thing, actually the whole thing, monthly. A private insurance, because it's private, because it's commercial, sounds more like buying a car. Okay, private insurance, you put a down payment. The higher the down payment, the lower the monthly payment. So you have a monthly payment, and then the deductible is that before you use the car, you have to pay $250 one time, and then at the end, the same thing. And then if you don't have a down payment, you go to a rinky-dinky place, and they're gonna send you a used car with zero down payment. We've all done that. We all bought a car with no down payment. But what happens with the monthly payment? Jesus Christ, it's a lot more than what you wanted, okay? But at the same price at the end. And Obamacare is telling you, okay, no down payment, no monthly, no nothing. Well, you have to pay a large deductible because at the end, all of the premiums are gonna be the same. I'm not saying that it's $1,200. I'm saying it's a good example to do, you know, divided by 12. That's why I use that number. But that's what it costs. They're not different. None of the insurances are different. The difference is uh, how you get to it. Okay, if all of us go to a dealership and buy the same car, and again, some of us put down payment, some of us don't put down payment, some of us do have some credit from something else or whatever it is. All those things matter for the transaction, but not for what you're gonna get. At the end, all of us are gonna get the same car or the same health insurance. So if it's Lane pays her, oh, okay, now let's say that if Lane has money, like she is, now she's saying, now when I ask her, do you have money? She says, I do have money, okay, like a lot of money. So another options could be that she wants to pay the whole thing. Let me raise, I hate when this happens. Wait, my bad. Let me raise like Champier, for example. Let me see if this works. I erase this one. Okay. Okay, I erase this one. Okay, and now I go for his name. You have money, right? Like a lot of money. So let's say this is you with a lot of money. Because you have a lot of money, you're gonna pay this insurance. And I ask you, do you have down payment? You go, yes. How much do you have down payment? Well, I have down payment of the whole thing. $1,200. Okay, then everything else is zero. So insurance is always if you have a good, if you pay out of pocket the whole thing, then I'm gonna help you out, give you a 90/10, but everything else is zero. Zero, zero, zero. So zero monthly payment, zero deductible, zero co-payment, 90/10, but at the end you pay exactly the same thing as everybody else. This is how insurance companies work. They sell you the insurance in many different ways. And Obamacare said everyone, basically the Obamacare, the premise was or is everyone gets insurance. But if you put a little bit more, then you get less deductible, less monthly payments. If you put the whole thing, then no co-payment, no deductible. If you just put a little bit into down payment or monthly payments, then your deductibles are gonna be higher. You wanna down, you're gonna get deductibles down. You need to have a higher monthly payment. You wanna have monthly payments go down, then you have to have a higher deductible. Again, this is like selling a car. Most of us have gone to a dealership, and you go in just to see if you can get a car, and you go out with a car. You had no money in the bank, no money in your pockets, and you end up with a car. How did that happen? Well, higher monthly payments. You bring a big chunk of money for a down payment. You're gonna get the same car, but now monthly payments are gonna be lower. So all of those combinations are the same when we're talking about health insurances. Yes or no? I think that's an interesting way of finishing this little section here. I hope you understand how all these things work. Just a little bit, doesn't have to be a lot. Next class, we're gonna do the chapter 13, and 13 is not 13, 14. It's gonna be Medicare. Okay, Medicare. So soon, and maybe what's day tomorrow? Maybe we'll do that on Monday. So one of the things that I want to do soon is register you guys for the NHA exam, and then we start thinking about when the date for the exam is going to be. So those things are pending. Actually, no, we need to So on Monday we'll do the NHA thing, and we are a little bit over halfway of the chapters. So we're gonna do a midterm uh, really soon, probably next week. So I'll let you know when and how. Um, and yep, as of today, that's it. Tomorrow we're gonna probably start and hopefully finish chapter 14, Medicare. Anything else? Any questions before I let you guys go?
I have a question.
Go ahead.
What would the hours be for the NHA exam?
That's why I need to figure that out. The we'll have different let's say this. We'll have different dates. We'll have at least two dates for you guys to choose from. And I'm trying to get testing to do it at night, just like the class. But I need confirmation for that still. The exam is 3 hours long, so let's say you could do 6 to 9, something like that. But the problem with that is that when the exam starts, everyone has to start. You cannot be late to the exam. So if the exam starts at 6 o'clock, you have to be there at least half an hour before. So let's say we make it start at 6:30, whatever. You have to be there at 6. If we make it start at 8 o'clock in the morning, you have to be there at 7:30. Simple, half an hour before. For you to enter your credentials uh, and um, and start. It's super simple, but everyone has to be like the exam start for everyone at the same time. After we start the exam, we lock basically we lock the exam, and nobody else can go into the exam um, after that. So it's not like you can get there late, start your exam later, and have your 3 hours, or start your exam later and have less than 3 hours. That's not going to work. So because of that, we need to, I'm going to ask you guys what your input is. We're going to do that tomorrow. And it's a 3 hour exam. You need your books, and you have to be there like half an hour earlier. In order to register for the actual exam, you're going to create your accounts probably next week. And then we're going to register for the exam 15 days before the exam. So 15 days before, it gives you enough time to do arrangements or whatever in order to get that, sit for that exam properly. One of the options is do it on a Saturday. I never like to do it on on a Saturday because it becomes a even more problematic and people don't get to the exam. So you cannot register for the exam and not show it for the exam because if you are a no-show without changing the date, you are going to lose the spot, and then you will have to pay for your exam. So there's a few things that we need to think about when we are getting ready for the exam. So I'll do my best to answer every question that you might have, and I will do my best to make sure that you guys get the dates. Can you do it on a separate day with separate for the group and whatever? Yes, but if you're gonna do that, you need to inform the department 15 days before, so they can actually open a session for you and get the testing department and stuff. Like that's kind of the rule. So yes, there's many ways. I was thinking that you might have some other options of going to maybe a different campus if it's closer to where you stay at. I'll still have to ask those questions. But if you are from the Hialeah campus and then you want to do it on Homestead, for example, then I can also figure out when the exam is going to be done at Homestead, and then maybe you can take it there. The Homestead exam should be 2 or 3 weeks after you guys finish. So your exam should be a week after you finish, and like 2 weeks after that will be the Homestead exam. So there's always ways that you can schedule it properly. So just tomorrow, make sure that tomorrow you have an idea, or at least some idea. I'll ask some questions tomorrow morning, and whatever answers I get, I'll let you guys know. And then on Monday, then I will create the accounts. You don't have to have the specific date that you're gonna take the exam that day, but we could do they're gonna ask you what day are you planning to take the exam. Okay, so we have to put kind of a tentative day. So we could talk about it on Monday. So again, long-winded answer. The hours and the dates is gonna be whatever we as a group decide, or whatever you as an individual that cannot be with the group decides. But there's a few things that we have to check first, dates, and you have to do it in advance. So, yep, that's kind of the next part. Any other question?
Perhaps would you be there in that day when we're taking it?
Oh, I can't. It's not. So the NHA, again, it is the rules that the teacher will have a conflict of interest if he or she is the day of the exam, so they do not allow it. That's why I'm gonna be with you guys in spirit. I'm gonna show you all the things that I know, so you can. Again, it's so funny. Like you'll see, because this class, I'll be your only teacher for this class. When you are listening to when you're reading the exam, you will be probably reading it like in my voice, and say, "Oh, this is how we do this." Whenever you have to do a calculation, you'll say like, "Okay, so a lot of minus," and you'll hear my voice saying it to you. So that's how I'm gonna be with you guys. And I know that it depends how things go, but I probably might have to even be there, but not while you're taking the exam. Are we going to have a practice test? Of course. So I was looking, and look, this is you guys. This is my super organized close with dates. We're gonna have 2 practice exams. Hopefully more than 2, but at least 2. And we're gonna do them closer to the end. So probably the last 2 weeks. So we're gonna have like 6 classes for that. So we're gonna have 1 the first day of the second to last class. So on the second to last Tuesday, we're gonna have a practice exam. Then we're gonna have the modules the next 2 days. Then we're gonna have the second practice for the codes, the second practice for the math, and then all around practice the last 2 days of class. So we have enough practices and enough days to do all of those. So, and we have 1 extra day just if anything comes out, but we're doing really good. I'm planning to finish in the next 2 weeks, finish all the chapters, and start with the practice of the CPT, HICPICS, and ICD books. So when we get to the practice of the books, it's gonna be 2 days per book, and then the rest is gonna be just practice for the exam.
Praise the Lord.
Oh. Listen, been doing this for a while. I always tell the students, if you see all the students that do this, do like whatever. Like, how many students go to college? Again, do you have an idea how many students are in Miami-Dade College? Like, it's the amount of students is incredible, and you're part of those. So I always tell the students to think like, why not you? Like, Why not Vanessa? Vanessa's doing it like everybody else. Why not? Why not you?
Amen.
You are just like everybody else, and you're capable of doing it. And this is people all over the U.S. that are doing this. Okay, so why not you? That's what I'm always
We
telling
got
you.
this.
So I'll do my best, and